And it's time now we take a look at some of the numbers and the trends that we have seen in the state of the coronavirus war. And first of all, we take a look at the numbers so far. The total infections in the country are 13,353. Of course, after 603 cases were reported yesterday. The total tests that have so far been conducted are 243,000. You recall that the target of the government was to hit 250,000 tests by the end of June. That was not met. You are yet to meet it, but the recoveries are 5,122, and that means that the active cases are 7,997, just 3 shy of 8,000, and the deaths have been 234. Let's take a look at how the numbers have been behaving. And this has been Kenya's worst week. That is the week that ended yesterday, because the cases a week before were 10,105, but the cases yesterday were, like I said, 13,353, and that's an increment of up to 3,245. This is the highest in any week since the pandemic hit the country on the 13th of March 2020. The new deaths that were reported in the 7 days were 49. That's an average of 7 deaths per week, per day. That's the highest since the pandemic. And then new recoveries have been 2,341, again, the highest for any week since the pandemic hit the country. Then let's take a look at how the curve has been behaving based on the weekly totals. And we are starting from week 7 when we reported 110 cases, but you can see how the curve has been rising, especially since the 12th week to stand at 3,345 now. The past 1 week has been the worst. The previous one was worse. Well, how do you say that? 2019 at that time, but you can see now it appears that the next week will even be worse, because now we are already reporting more than 600 cases on a daily basis. We'll be comparing that curve with the UK curve later on. But first, Kenya's worst month is also the month of July, because so far we've had a daily average of 367 new infections to give us a total of 6,987 in the month of July. It's just been 19 days. If you compare that to June, which had 4,404 cases in the entire 30 days. Let's take a look at other trends that would go to the pandemic. The tests in June were 89,000, the infections of 4,400, and the infection ratio, the positivity of cases was 4.9%. The deaths in June were 82. I'll compare that figure, that percentage, with that of July, because it has really changed from 4.9% to now 9.4%. And this means that for every 100 cases, 100 persons that are tested, 9.4 are positive. Or if you may put it as for every 1,000 samples, 94 are positive. So because in the month of July, 74,000 have been tested, and the infections are at 6,987. So that positivity ratio is rising on a daily basis. The deaths have already been 86 and rising. Let's take a look at the other numbers that would give us how the cases have been spreading in the regions. So Nairobi region, of course it's just a city county, appears to be in the lead, because 7,739 cases reported. If you go to the coast region, which follows not very closely, just distantly, it has so far 2,054 cases. What follows is Central Kenya, no, Rift Valley actually. Rift Valley with its 14 counties, 1,141 infections. Central Kenya following with 815, but most of them are in Kiambu. Northeastern, no, actually Eastern, no, Western. Western follows with 669, then Eastern region follows with 541, then Nyanza with 319, and finally Northeastern with its 3 counties has 75 cases. Let's just take a look at some of the leading counties in terms of infections, and you'll see that Nairobi continues to be in the lead, of course, being a region and a county, and it's followed by Mombasa, which has 1,834. And then you will look at, it should be Kiambu. No, Kiambu actually has more than 334. It should be somewhere around 734. Then Kajiado has 663. Busia has 635. Then Uasin Gishu 116, Nakuru 195, and Migori 215. So those are just the numbers, how they're looking in the country. And let's now cross over to the United Kingdom, because we know that they have also been dealing with the pandemic, maybe for longer. They have more experience than us. Should we begin with the curve? I think so that you see how the numbers have been rising. These are a curve that was shared with us. Well, this is the Kenyan curve that you see. It's sort of a weekly tracking since the pandemic since the 7th week to where we are now with the weekly readings being 3,245. Let's compare that to the UK one, because that has gone already to the peak and flattened and is it so? And started going down. Well, I'm waiting for it. So there it is. But I can't see it. Okay, so here it is. Daily confirmed cases of coronavirus in the UK. So you'll see from 15th of March when the numbers were not as high, then it went up. I think the highest must have been sometimes at the start of the month of May. And now currently 7-day average at 621. So that's what they are doing, 621. But they have been up and now going down. So if the average is at 621, and currently our average is at more than 360, and you're heading to more than 600 cases on a daily basis, we might be somewhere around the same place. But Tabitha Kavoy joins us from the UK. Good morning, Tabitha, and thank you for joining us on Daybreak. And let's begin with interpreting this curve that we are seeing of the UK versus that of Kenya. So, of course, the UK has been to the high numbers. They have reached a peak, now going down. What more are you seeing?
Right, Sam. So thank you for having me this morning. So in terms of the UK curve, it's good to say that COVID was first came into the UK in January. And by around March, that's when we started seeing an increase in cases, a huge increase around April. And then from around mid-April, we started seeing the cases going down, and they've gone down up to now. So our peak was around mid-April. So comparing with the Kenyan cases, you can see that it's around 19th of March that we had around the 400 cases a day. Mm-hmm. And the story quickly changed, because a week later, it was 1,000 cases a day. And by the time it was mid-April, it had gone to about an average of about over 4,500 cases a day. So it changed very quickly. Within a month, it was into the around 4,500, around 6. So you can see there's a bit of flattening of a curve between 15th of May, 15th of April, and beginning of May. Right. And what we've seen is that curve has continued to go down and is sort of stabilizing at around 621 at the moment.
Mm-hmm. And of course, I asked that question because, like I showed you there with the weekly tracking, it would appear that now we're at that point that with more than 3,245 cases in a week, Kenyans are concerned that we were reporting less than 100 cases not so long ago. Now we are doing 603 as of yesterday. What should we be prepared for now?
Okay, so I think what we saw when our cases were improving is obviously we had a really high number of deaths. I mean, so far we've had over 45,000 deaths in the UK. And as the cases have gone down and we are at 621 deaths, an average rolling of 621 deaths, what we've started to see is, rather than a national outbreak, we've started to see local flare-ups, local outbreaks in either specific workplaces or specific local places. And what we should, and again, what we've seen is what COVID has laid bare is health inequalities, where we're having the worst people, the most deprived people affected the worst. So it's not an equal impact. So it's just showing the existing health inequalities, that it's just exacerbating this and putting this bare out there. So I think for us, what we are doing and what I think Kenya should do now is have a good trace and track system. I think it's very important to find out, where are these cases coming from? Who are these people? You know, is it community infection? Is it hospital infections? Mm-hmm. Is it people coming into the country? And finding out where these infections are. So that's aggressive testing. Also contact tracing their contacts and isolating them, advising them to isolate. So when you do that, what you tend to do is you break the chain of transmission. That's what public health is, and you're able to control the rate of infection.
Mm-hmm. And of course, it would be important to benefit from your experience, of course, observing the spread of the virus in the UK, because yes, there's a time that you are reporting the numbers that we are reporting. And like I told you, Kenyans are concerned. What are we expecting to see? Because yes, the containment measures have been there. There have been a relaxation the past, I think, 3 or so weeks now, actually 2 weeks. Should we be expecting more infections, and how do we deal with this, because it's likely to happen?
Yeah. So as I said before, Sam, is when you're in lockdown and you look at the UK curve, you realize that after the lockdown measures were put in end of March, we saw 2 weeks of an increase in cases. So that was up to mid-April. And then after that, we saw the cases begin to go down. So naturally, with any infection is when you ease lockdown, what you expect to see is an increase, a slight increase in cases, dependent on how people behave. It's dependent on people behavior and dependent on how effective the containment measures are. So for me, lifting of lockdown needs to be slow, it needs to be gradual, it needs to be informed, but at the same time, people need to be vigilant and keep an eye on it. So as we see the spikes rising, we're able to intervene and deal with those infections before they get any further.
And maybe you can help us understand the containment measures in the UK currently, because yes, we see that your numbers are now on the decline. What are the measures that are still in force, and how are you dealing with the relaxation that would be gradual?
Okay, so the last time I spoke to you about a month ago is when we were starting to open up. So the government opened up some schools, so some crucial years of primary school were opened, and a bit of non-essential shops were open, so things like pubs, restaurants were open. And I think we are by the beginning of August, I think we are going to see a lot of other non-essential shops like salons and things like that opening, and people who've been shielding have been asked to go out. Now, again, it's not back to normal as yet. Although we are seeing things get back to normal, we are still putting in place social distancing measures. We are still advocating for hygiene, and it will be compulsory from this end of this week to wear masks in any public spaces, in public transport, in shops. So it's a combination of measures that's helping with that. But as I'd said previously, Sam, it's very, very important to track where the infections are, because that's the bread and butter of public health. That's the bread and butter of infection control. You have to trace, you have to know where the cases are coming from. You have to test, you have to trace the contacts. And by stopping the spread of the disease, that's how we'll be able to reduce the cases going up.
Right, and let's talk about the disease burden, especially on the public health system in the UK, because in the country, just over 1,000 are the persons that are currently admitted out of active cases of more than 7,000. And there's this issue about home-based care that is now taking root in different parts of the country. How exactly are you dealing with it in the UK, and how have you ensured that the coronavirus pandemic does not override or overrun the healthcare facilities of the public sector?
Okay, so in the UK, when COVID or the cases started rising, there was a quick measures were put in place to increase our capacity in the hospitals, so critical care beds. And apart from the existing capacity, the government built very quickly, which is a precedent we've not seen before, 7 new hospitals to support the existing hospitals. And they were built in different regions of the country, so in London, in Manchester, in Liverpool. And like, for example, the London one was about 4,000 capacity, the Manchester one, the Birmingham one, a similar capacity, the Manchester one, about 1,000 beds. And I think the idea was for these hospitals to support the existing hospitals so that there isn't an overwhelming of the system. And I think in the beginning, we were talking about flattening the curve, not overwhelming the system, because we knew how that could impact, what a huge impact that could have if the hospitals were overwhelmed. Now, when we're looking back, even when we had the highest cases, only 60% of our existing actually critical care capacity was used. So we never surpassed that, but at the same time, the new hospitals that were built, we've ended up actually they were not used as much as we thought they were, because the cases didn't get to the level that we thought they would. So the hospitals are still in standby; they've not been put down. They're still in standby, and we are waiting because we're approaching the winter season very soon, and we tend to get high levels of flu. So the hospitals are there in standby. So just in case we are dealing with high levels of flu, and in case we get a second wave, we are prepared. We are better prepared than the first one, and so they are still there, and the capacity is still there. But at the moment, it's less than a third of the existing NHS capacity that's being used for COVID.
That is such a contrast, because in Kenya, the county governors are working day and night to ensure that they're able to at least put in place at the very minimum 300 bed capacity for isolation and sometimes for treatment as well. So I don't know, because of all these disparities, and you've been in Kenya, so you know the differences. I mean, what can we do? What are the quick wins that we can deploy to be in a position to ensure that we save as many lives as possible?
So I think it's worth prioritizing who really needs to be at the hospital. And I think for us, that was key, who ends up in the hospital, because the people who ended up in the hospital are the critically ill people who are able to manage the symptoms, what were treated and advised over the phone and isolated at home. So the hospitals are only used for people who really needed them. And I think that's something that we'll have to look through into our system, because I think, having grown up in Kenya, I do know that how the health system works, and I do know we tend to use the hospitals a lot. But if people are well and they're managing, they don't need a doctor 24/7, they don't need the ventilator, I don't see why they cannot isolate at home and probably be seen from there or get advice virtually from their doctor and be able to manage the conditions that way. This way we'll be able to ease the pressure. This way we'll be able to keep the hospitals for people who really need them. And especially in the counties where the capacity is not as much, this will help in terms of ensuring that capacity is kept for people who really need it.
Mm-hmm. And obviously, of course, like I told you earlier on, the past 1 week has been the highest in terms of fatalities reported, talking about 49 deaths. Of course, if you have to compare this to the situation in the UK, then it will look like apples and oranges, but all the same, they are deaths. And Kenyans are starting to get worried that we are reporting more sick patients. Have you seen the same in the UK? And is it because the virus is evolving, or is it just how it's affecting different people in their different communities?
I think you're right in saying we cannot compare the UK with Kenya. I think, one, we need to recognize these aren't just numbers, as you just described, and I said the last time, behind every number, behind every death, every case, there's a family, and it's obviously having an impact on people and people's lives. Now, in terms of what we are seeing is, in terms of demographics, again, there's a difference. We've got a high aging population in the UK, whereas in Kenya, it's more of a younger population. So that, again, affected the number of our deaths in the country. So we saw a high number of deaths, people with pre-existing medical conditions, the elderly were the worst affected. Now, that's not to say that obviously there weren't people who, we also had a huge percentage of people who were asymptomatic. And being asymptomatic, meaning that, they were found to be cases, but actually were not showing any symptoms, or they were not, they were not sick. Mm-hmm. So again, as I said, people who use the hospitals, or people who were taken to the hospitals, were the critically ill people, were people who really needed to be, in the care of a doctor there and then. But the rest of them were isolated at home, given advice, and actually just advised on what to do in order to manage those conditions. So I can understand why people would be worried. I mean, it's worrying, it's affecting everybody. I can understand all of that. But again, the demographics are very different from what we have in Kenya.
Mm-hmm. Probably, if you may benefit us by telling us the sort of care that people are being subjected to, because there are different categories of patients. There are those that are asymptomatic, there are those that are symptomatic, but then again, there are those who are pre-symptomatic. So what are the regimes that you're deploying for all these stages of patients, whether they are to treat from home or they're to be admitted in hospitals?
So if I had, at the moment, let's just go back to our testing regime, Sam. So the UK, when we started testing for COVID, it was very focused on symptomatic residents, so people who were showing symptoms. And what you did is, if you were showing symptoms, you rang a number, and then you were sent a test. So you either went in, so there's a lot of testing regimes in place, there's the regional ones, there's regional centers, there's mobile testing units, or if you couldn't drive, or you were sent a home testing kit where you would test yourself, and that was sent back. And that capacity has increased. I mean, the capacity, we were starting with 25,000, now we are talking about 250,000 tests a day. Mm-hmm. And as that capacity has has increased, and as we've continued to learn about, as the virus is evolving and we're getting to know more about the virus, again, we've changed our testing criteria and we've changed our model of testing. So at the moment, there's a lot of trialing of asymptomatic patients as well, residents as well, but those are the people in care homes. You know, as I've said, we've got an aging population that's looked after in the care homes, and so we are doing asymptomatic testing there for their staff, for the residents, just to make sure that, because you can imagine if you're in a care home, it's an enclosed place, it's a lot of people. When the virus does get through, it spreads very quickly. Mm-hmm. So that's what we're doing. People who are well, as I said again, people who are well and are managing the symptoms are at home. They're not in the hospital. So the hospitals they're very ill, and there's sort of a triad system. So if you're really well, you ring the emergency services and they talk through how you're feeling, and then an assessment is done if you need to go to the hospital or if you need to just stay at home, and you're given advice on how to manage that.
Mm-hmm. And let me just ask you this. How are people dealing with, of course, the fatigue that comes with the containment measures and the psychological disturbance that would appear to affect especially those that are sick and the families of the sick?
Okay, so we need to recognize that COVID is just not a physical disease. You know, it's having a lot of mental impact, as you alluded to there. So, you know, first, people are at home. If you're locked down at home, for example, we're locked down for such a long time, you don't see other people, you're not socializing, people are worried about jobs, people are worried about losing their loved ones. So it comes with not only an impact on health, but also an economic impact and social and physiological impact as well. So there's a lot of support systems that the government has put in place in terms of the economic measures, but also locally, the local councils have put in place support systems to support people with mental health. Charities have come up where people can ring up, where they help hubs, where people can ring up, they can talk to people, they can be helped. Like, for example, if you're elderly and you need medicine or you need shopping, the use of volunteers to do that, and a huge community, you know, cohesion, and people just willing to step in and help each other. So, you know, there's help. Of their websites are pointing people to help in terms of calling and things like that. But in terms of, again, I think you've asked a very good question on people wearing out on the measures, and it's difficult, and it's difficult for people when you've seen COVID. It's been on for weeks, and people are bound to get tired of being asked to take the measures. But I would urge people to just be little bit more patient. But on the other hand, the government has to engage the people, the public. They need to feel engaged. The message needs to be clear. You know, we can't afford to give messages that are not clear. The directives need to be clear. They need to be simple, easily understood, and then people will engage and will take ownership of that.
Mm-hmm. Right, and let's focus on the interest of every individual in this world at the moment, and they are looking for a vaccine. We've heard of reports in the US of the final round of testing that they should be starting in the next few days, and they are saying that the earliest that we can have a vaccine is towards the end of the year, but of course for global scale maybe up to next year, mid next year. What is the progress that has been made by the UK systems in as far as finding a vaccine that would work for COVID-19?
I think what we need to recognize, Sam, is obviously when COVID started, medical scientists have been working round the clock, you know, around the world, and there's a lot of collaborations to try and study the virus, understand its behavior, understand the antibodies, understand the immunity in order to develop a vaccine. So there is a lot of progress locally in the UK for a vaccine, and a lot of research apart from just the vaccine has come up. So, for example, we now understand about asymptomatic people being asymptomatic. We now understand that COVID has long-term impacts on health, on lung health and cardiovascular health. So there's a lot of research ongoing. In terms of the vaccine itself, we know that there's progress. It's difficult to say exactly when. And the reason why I say it's difficult to say is because a vaccine has a long process. So they're producing this vaccine in the lab and you have to test in the lab. Then you've got the preclinical stages where you try with a few number of people. Then you've got the phase 1 where you try the number of people for efficacy to understand the safety. Then you've got the phase 2 and the phase 3 before you even roll it out. Mm-hmm. So I'm hopeful, I'm positive, but I'm not expecting anything in the next few weeks. So about 12 to 18 months, because we've got to test it and make sure that it works.
Wow, 12 to 18 months, that's a long time.
Yeah, it is a long time. I mean, I'm just being realistic here because, for example, let's say even if we found a vaccine today, a vaccine was found today, it's got to be tested at, you can't just give it to people. You've got to go through all the stages, all the trial stages, make sure it's safe, to make sure it works. And again, it's a new virus. Let's not forget that. It's a novel virus. We're still learning a lot about it. We're still trying to understand how it behaves. So it's important to give that time for it to be safe and for it to be effective, and again for it to be produced at levels that are available to everybody, as you know, especially in our country, Kenya, where it's a third world country. So it needs to be they need to be able to manufacture it in quantities that are fair and available to everybody in the country, not just the Western countries.
Right, and Tabitha, I want us to conclude this, and finally, of course, now you've seen where we are as a country, 13,353 cases reported. If the trend continues, then by the close of today, we'll be at more than 14,000. So what do you say to your countrymen in as far as what you've seen in the UK and what in the next few days or weeks would portend in as far as the pandemic is concerned?
Okay, so I think what I would say to my countrymen is COVID is here. Obviously, as we've discussed, there isn't vaccine, so it's here, and I don't want to be the pessimist and say it's here to stay, but for now we know it's here, and we're going to be dealing with it for a very long time. So my advice to my fellow Kenyans, one is for the government to continue giving clear, reliable, simple instructions and advice, communication to the public, and also to make use of data, Sam. So I do know that we have the daily briefings and they talk about numbers as you describe them, they talk about deaths, but I think there's something about public ownership of that. What does that mean for the common wananchi, for the common Kenyan? What does it mean for them? And I think that's what people are looking for, to adhere to that. So clear guidance, clear communication from our government, using that data to work with public health officials to find out where these infections are and try and break the chains of infections. But then to our members of public, I think, one, let's not forget the public health measures that are in place. Social distancing, where are we going? Is it necessary? Do we need to be there? Is it COVID secure? If you're visiting a restaurant or pub, we need to keep everybody accountable. Is it COVID secure? Are we washing our hands? Are we wearing masks, and are we wearing them properly? So not under our chins. It's not a fashion. We need to take them seriously, wear them properly. The other two other messages I would like to pass is, one, do not be a contact. Do not be a COVID-19 contact, because if you're a COVID-19 contact, you've passed that on. And as we've seen, as we've discussed, you could be asymptomatic. So you could be passing the virus silently when you don't know. So do not contact. And finally, Sam, I think I would like to address stigma, which is a very important issue for us, given our cultural issues in Kenya. Stigma, as we've seen in other outbreaks, like in other infections like HIV, TB, once you start stigmatizing the victims, then it becomes really difficult for people to come forward to get tested, for people to come forward to get treated. So let's be careful about stigmatizing our COVID patients, and also let's be careful about what do we post on social media. Think before you forward it, think before you repost it, and let's be there for each other. So let's again play to our strengths of Harambee and do this together, and we can do it. We all have a part to play.
Tabitha Kavoy, thank you so much, of course, a public health specialist in the UK. And thank you for sharing your thoughts and your experiences with your fellow countrymen. And we hope to speak to you soon as the COVID-19 curve in the UK continues to drop.